Hello, everyone. Thank you for joining us today. I'm Jamie Pina, the new Vice President of Public Health Data Modernization here at ASTHO. You are in Breakout D, Prioritizing Equity in Data and Research. Today's session will be a conversation with leading experts in the field of data, research, and evaluation. This session will highlight the critical importance of framing data and research to advance health equity by addressing the root causes of health inequities. We'll focus on authentically engaging communities and being intentional about how we collect and use data. We'll also discuss how to address racism and inclusiveness in research. We'll be taking limited questions for today's event, and today's session will be in listen-only mode, and closed captioning is available. The session is being recorded and will be posted a few days later following the presentation. Session materials and full bios will be located in the resource tab. And with those housekeeping items out of the way, I think we're ready to begin. So the opening question that we're going to address today is, what are some practical data-driven approaches for advancing racial equity? And our first respondent will be Dr. Tracy Hillard from the Center for Culturally Responsive Engagement at Michigan Public Health Institute. Dr. Hillard. Dr. Hillard, I think your microphone is muted.
Yes, thank you.
Sure.
It's a pleasure to be here with all of you. I'll share some slides to guide our conversation. As Jamie said, and thank you, Jamie, and all of the folks at ASTHO for the opportunity to be here with you today. Wanted to first start by answering that question about 3 questions that everyone can consider for addressing health equity. And on the screen, you'll see a picture of an inclusion power map with 3 questions. Those are, who holds the power that influences policies and outcomes? Who was engaged and empowered in the decision-making process? And who's missing? And it's just a coincidence. This is a slide that I have ready to go and share on behalf of MPHI and our Center for Culturally Responsive Engagement all the time. It wasn't something that I prepared just in response to our prompts today as panelists. And so for a moment, I'll just walk through kind of this circle that you see around how decision makers are influenced. And we know in society, we all make decisions in various capacities. So just generally speaking, starting in a clockwise fashion from the top, your friends. I know often as a sociologist, people always say, you're more like your friends than not. Business associates. So in business here, we are at ASTHO. We're in a community of practice, I would think. Your family. We all should think about our background and family in terms of how we've been raised and our perceptions and thinking and approaches to life. Certainly media, I think in recent years with advances in technology, we see so many impacts on various forms of media, et cetera. Questions, there's always things that are unknown that may influence decision-making. Advisors, who might be influencing you? That may be any number of the networks that we've already mentioned. There may be other types of influences you need to consider. Of course, donors and supporters. We know that often funding drives quite a bit of decision-making. And then staff. I also would call you to think very critically about who's staffing a project or an initiative, and what's the makeup and the composition of that staff. And so as you think about all this, I also just call to attention how we think about structural racism and systemic racism, particularly as we think about the impacts on health equity. I think it would be tone deaf if I didn't acknowledge that we're coming off of a historical verdict in the United States yesterday that really the entire world, I believe, has been watching for the last year in terms of the murder of George Floyd. I can call it the murder of George Floyd since there was a conviction as of yesterday. And I call that to your attention as an example as we think about racism and addressing equity in all forms, particularly racial equity, because that was an example that, again, the entire world was able to see. And I also called to your attention the idea of perceptions. We saw the civil unrest around the world in response to the murder of George Floyd last year, because everybody perceived with all of their senses what happened because it was recorded by video. And I thought to myself yesterday with that verdict, isn't it interesting that so many people want to celebrate the fact that there was a verdict finding the suspect at the time guilty, when really justice was served. I think so many people with their own perceptions knew what happened, but as you think about our systems and processes in our country, obviously that system is laden with a history where justice might not be served, and people might not think that we can rely on that system to bring truth and bring equity in our society. Also want to acknowledge, going to another slide here, I'm going to stop sharing just a moment. Thanks for bearing with me. What it looks like to address your work with a culturally responsive and racial equity lens. And that's the hallmark of what we do at the Center for Culturally Responsive Engagement at Michigan Public Health Institute. So as you think about doing this work, I would say always place the people who are most impacted at the center of the conversations which seek to find solutions to the problems affecting them. What does that look like? Again, mentioning how you might assess the diversity of your team, thinking about the service providers or researchers or funders, and do they look like the community most impacted? Reflecting on the cultural competence of the team. What's their cultural awareness and humility and sensitivity to those that they're aiming to serve? Reaching out to community leaders and agents. Again, thinking about who's at the table and who's influencing all of our thinking and decision-making. Ensuring that community voices are heard and valued. Again, who's at the table and who's missing. And examining those institutional or interinstitutional aspects of structural racism. Again, knowing that all of us typically have been trained in institutions that have historically been designed to uphold power for some and oppress others. Whether we like it or not, that's the systems and the fabric of our society. And thinking about that and understanding there's a racial historical legacy that is not necessarily anything that we may be responsible for, but we have the power and authority to change. And particularly as we think about our work in health equity, to identify those racial disparities. We know that equity comes in all forms and there's many intersections. And again, just thinking about the example that we saw yesterday, knowing the power of race in upholding a lot of the inequities we see in our society. So with that, I think that's my introductory time, and look forward to our conversation, and we'll pass it on back to Jamie. Thank you, Jamie.
Thank you so much, Dr. Hillard. Okay, the next speaker is Ms. Dietrich Epps, the CEO and founder at Race for Equity.
All right, good afternoon, good morning, and good day to everyone. My name is Dietrich Epps. As Jamie shared, I'm the CEO and founder of Race for Equity. We are a global management consulting firm, and looking to share with you today about prioritizing data and equity in research. And as we speak together, what I'll talk to you a little bit about is the Race for Equity approach. We'll have some time to go through these slides, about 5 minutes. And then just after that, we'll have a little later, some questions that I'll go hopefully into more detail around some of the things that have been mentioned here. So the question, what are some practical data-driven approaches to advancing equity? We have a program called Building an Equitable Results-Based Organization. And as a part of that, we start off all of our work with an acknowledgement and honor. As you read through this slide, you'll see that it is really, Dr. Hiller just shared about culturally responsive approach. And so we recognize that it's important to start with the historical context and the cultural context of the communities where we are based. So this acknowledgement and honor, we do at the beginning of each of our sessions. And so I'm going to ask you to read through it silently. I'm not going to pause to go in depth into it at this time because of time constraints, but we acknowledge everyone who is on this call. And I recommend that you take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here on today. So there is a challenge that we know about including people with a lived experience in the decision making when you think of this approach to improve racial equity and using data to make decisions. So the first challenge is an authentic engagement of people who are directly impacted by the decisions throughout the processes, including the selection and the collection of key data. So as a part of the Race for Equity approach, we have an action example. This is one example of our equitable community engagement continuum, but we recommend that you engage numerous diverse people with the lived experience from different cultures from the beginning of any process that you engage upon. And so what this might look like is before we talk about the words buy-in and getting buy-in into a process, we look at the people who are impacted being a part of the process from the beginning so that they are engaged in the development of the work together and actually, ideally, leading the experience. This is another tool that we use within the Race for Equity approach. It's called the Intercultural Development Inventory. We focus on understanding not just cultural competence, which is a term we'll probably talk about, but not just cultural competence, not just linguistic competence, but really understanding intercultural development. How well are people engaged in the process, understanding and able to shift their understanding of different cultures and their ability to adapt their behaviors based upon the different cultures that are a part of the groups that they're working in. So you see on this intercultural development continuum that today's, I'll just give an example. In our society today, our culture today, we see a lot of polarization where people are judging differences across culture. And that is very problematic. It creates a us versus them framing. And what we want to move toward is adaptation, where we are bridging across cultural differences. This is an example of how we can authentically engage people from diverse communities. Another challenge that has been identified is the use of disaggregated data to guide decision-making with community partners and organizations. How does the data tell you, what does the data tell you about people who have been historically marginalized? How are they doing? And how transparently is that data shared? The Race for Equity approach includes the use of a framework called results-based accountability, which separates the data very clearly into population level data. I know this is the busy slide. I didn't want to kind of take time to go into depth with it, so I'm just doing this one shot. But you'll see at the top is population accountability, which is about the well-being of whole populations. And you want to make sure that your strategies at the population level are culturally responsive strategies, and that you have disaggregated data that tells you how marginalized populations are doing. The second part of results-based accountability is called performance accountability, and that's at the bottom. And this is about the well-being of people receiving services. So once you're sure that the strategies are the right strategies for the specific cultures that are a part of your community, you want to think about, once people come to the programs or the services that you're offering, how well are you delivering those services, especially for people who are marginalized? There are 3 core questions. How much did we do? How well did we do it? And is anyone better off? But we want to make sure that that data is, again, disaggregated by those specific populations that you are intending to serve, and how are those individuals doing specifically on these programs and strategies. I wanted to give an example, a clear action example. The National Equity Atlas is a fantastic tool for you to find data on indicators around equity. There's research, there's data in action. Policy Link, many of you may be familiar with it, but if you're not, this is a great place to start as you're thinking about data that shows you about equity across different communities and across different populations. So I'm going to stop there, and just because of the time frame that we have available to us, and will be available for questions afterwards around anything that was shared so far.
Thank you so much, Ms. Epps, for your response and summary. Our next speaker is Dr. Chandra Ford, professor in the Department of Community Health Sciences and the founding director of the Center for the Study of Racism, Social Justice, and Health at UCLA. Dr. Ford, your response?
Thank you. So I do just want to start by saying what a privilege to be here at this awesome conference. Thank you for the opportunity, and I look forward to having conversation with my esteemed co-panelists. And I want to thank everyone here at ASTHO, because you all show up every day in the field. Some of you traveling far to the front lines, and others of you not traveling so far to battle for the health and safety of people in diverse communities every day. In the time allotted me, I just want to introduce 3 sets of resources that offer concrete tools for addressing racism as a public health issue. But first, allow me to acknowledge that I conduct my work in Southern California on lands originally inhabited by and cared for by the Tongva peoples. Barely 2 weeks ago, CDC Director Dr. Rochelle Walensky declared racism a threat to the health of the public, and that declaration is historic. And while its implications for our work will become clearer with time, no doubt many of you are wondering, what can you do today to address racism as a public health problem? So the resources that I'm sharing are not, and they are tools that any public health professional can begin with, regardless of where you are on your own personal journey towards being on your own personal anti-racism journey. 3 excellent, very straightforward books with which to start are shown here. And for each book, I've listed just 2 strategies that are within the book. You'll have to go inside each of the books to find out the details on how exactly to implement them. But I just wanted to highlight 3 specific strategies. My co-editors and I wrote Racism, Science and Tools for the Public Health Professional because, as we write in the introduction, quote, in general, the responsibility to reduce, remove, or eliminate public health problems rests with public health professionals. However, significant gaps exist between the science on racism and the tools public health professionals have at their disposal to address it. So this book, 2 of the strategies that I think are useful coming from this book include collecting actionable data and using approaches and measures that communities have already tried. So in terms of collecting actionable data, think about just how improving how we collect data on our intake forms on race and ethnicity could actually improve how researchers are able to study the effects of racism. So with respect to COVID-19, and these are data from the COVID tracking project back in the end of March when they stopped collecting data. And Dr. Kendi is really familiar with this data set, obviously. And you can see here that Asian populations, first of all, just as background, have been impacted heavily by hate crimes and hate incidents during the course of the pandemic. Native Hawaiian and other Pacific Islander populations have been impacted heavily by COVID, structural ways that racism affects populations. And often we clump together Asian and Pacific Islander. But as you can see here, if we do, we miss the fact that Pacific Islander and Native Hawaiian populations are experiencing 132 per 100,000 population in terms of deaths, whereas Asian populations are experiencing 87. So disaggregation, as mentioned earlier, is an important way to improve data collection. Unequal Treatment, which was published more than a decade ago, shines a light on the ways that racism operates within the healthcare system. So monitoring how people are treated within healthcare, not just in accessing healthcare, is important. Here too, it's important to recognize that we may need to develop the systems and practices that enable us to monitor what's happening within the healthcare system. So much of the ways that racism operates in the healthcare setting, like elsewhere, is not overt. And so it's important to consider the unintentional ways that racism operates in the healthcare setting. And then finally, Communities in Action, which was a then National Academy of Medicine project that I was fortunate to be involved with. And it's not focused, the entire project is not focused specifically on racism, but it does recognize structural racism as a driver of community inequities. And it calls for us to build multi-sectoral coalitions to address this driver. Those coalitions should engage diverse stakeholders, often stakeholders who are at odds in terms of their interests, and include anchor institutions such as banks and other private sector entities. So that's one set of resources. A second set of resources is those that come from the public health critical race practice. This is a model that Collins Ariambua, noted health educator Collins Ariambua, and I developed some 10 years ago to incorporate anti-racism strategies systematically and rigorously into health equity research and practice. The book covers some ways to do it in practice. We have focused largely on, the literature focuses largely on how to bring it into research. But all of the work is aimed at understanding how is racism affecting the health disparities that are happening in society. And at the same time, how are we as researchers or practitioners and our field shaping understandings about racism, those racism and disparities. It involved a 4-stage research process that entails taking a very explicit racism conscious orientation at the beginning of any endeavor, then assessing what are current racial dynamics that are salient to this work, clarifying how biases embedded in the field, racial biases may be embedded in the field and affect this project. And in light of these two considerations, operationalize measures that are aware of and accounting for these considerations. And this work always aims to make some commitment to taking some kind of action, however small, toward addressing the inequities that we are studying. It may not be possible to fully implement the full process. However, just drawing on these core principles, which serve as a lexicon for this praxis, can really help to move our field beyond racism 101 toward deeper understandings of racism and providing us with the shared language that Dr. Kendi mentioned earlier that's needed for us to advance collectively. So that's the second set of resources. A third set of resources that I'll just mention briefly, in an exciting new project with my colleague Monica Ponder at Howard University, we're developing resources to support health departments, communities, and so on in documenting and addressing the ways that racism is a public health problem in the context of pandemics, in particular COVID-19. So this project offers resources that are community informed, addressing racism and the ways that it's salient for the pandemic. So I know it can be hard to know where to start and how to proceed. I would encourage us to let the fear, set the fear aside and just begin to take steps. And to do that, I offer one challenge to each person here. And that is to just identify and use just one existing resource to take just one concrete action toward racial equity by next year's meeting. And my commitment to you in this process is to support the association in developing anti-racist health equity strategies and advancing them association-wide. Thank you.
Thank you, Dr. Ford. And thank you also, Dr. Hillard and Ms. Epps, for your opening remarks. I'm inspired, and it's wonderful to hear your thoughts as we're beginning our discussion. A few points I thought I would draw out to frame our discussion were these. Some common threads across all of your opening remarks. The first was that there's a strong need to recognize the past, to recognize the history of our country, and to approach that without fear as we approach topics of research and data-driven activity. The second, which seems to be a common thread across all of your presentations, was the need to engage diverse stakeholders from the beginning of the work that we do, and to consider who holds power and who is missing in those discussions. And finally, to accept and recognize racism as a public health problem. At ASTHO, of course, we support public health practitioners at many different levels. And the recognition that racism is a public health issue, I think, frames it in a way that makes it easy to understand for people who are in the applied field of public health. So I wanted to kick off the remainder of our discussion today with a question about the difference between interpersonal racism and institutionalized racism. And this is based on the feedback that you provided. I was wondering if you had thoughts about what are the processes or procedures or events that occur that transform interpersonal racism into institutionalized policies that reflect racist beliefs and behaviors. And I'll open that up to whomever of you would like to begin, and we can discuss.
This is Tracy. I think this is probably just scratching the surface on a response to your question, Jamie. Appreciate the question. I'm mindful of just thinking about who we have in the room. That's been one of the themes today, is who's in the room when you're making decisions and thinking about how we can come together and address health equity, particularly in our case through research and data and evaluation. And I'm just mindful, let's think about who's convened this today. ASTHO, Association of State and Territorial Health Officials. I appreciated you referred to everybody as practitioners. I go back to also just the O, the officials. And that reminds me that all of us are gatekeepers. And so I encourage everybody to think about how we are gatekeepers of the resources, of the services, of the opportunities for everyone that we serve to be their healthiest selves. And as we address the systemic and structural racism and inequities that we know are multifold, multifaceted, how are we as gatekeepers either upholding things that are probably handed down to us traditionally for decades, centuries? how are we upholding that, or how are we pushing to seek change? So I'll just start with that and open it up to the group.
Thank you, Dr. Hillard.
So I'll go next. What comes to mind for me is that there is a lot of fear in place right now. I mentioned the intercultural development continuum and how polarized our society is right now. And people are afraid to even speak in groups without, and say something inappropriate. And it's understandable. We're living in a sensitive time, and we want to be sensitive to individual words because words have impact, right? And so people want to be careful with their words. But at the same time, we have to live in we have to create safe, brave spaces for people to feel like they can speak and they can address openly when they see things happening that are impacting at an individual level, impacting someone individually in an office, in a workspace, in a work culture, and then speaking out when you see something is impacting a whole community of people disproportionately. And it takes bravery. Courage is not a big giant act of running into a building of burning people. Courage is an act of speaking up in a room and saying, you know what, we've been doing it this way for a long time, but there's something called the social determinants of health that we always talk about. And I'd like for us to think about racism as part of that social determinants of health. What do you guys think about that, right? So that takes a lot of courage. It flowed off of my tongue because I'm accustomed to saying it. I feel confident about it, but not everyone will have that same sense of confidence. So my first step, and I love what Dr. Ford said about a challenge. My challenge is for folks to be courageous and to, have that courage. Brene Brown says the act of courage is couraging. Like you have to start couraging and being encouraging in these environments. And an active way of doing that, an action step, is asking your health group, a health equity group, to think about racism as part of the social determinants of health and how to address that as part of it.
I love what you all are both saying because it gives us actions to do, things to do. In terms of thinking about how racism is working at the interpersonal institutional levels, I actually would shift it to pose the question really the opposite way. How are the institutional factors and structures driving what happens at the interpersonal? Mm-hmm. So much of the work that has been done in the healthcare setting is about implicit bias. And implicit biases, it's important to understand, are not arbitrary individual level biases. It's not simply that, I like oranges. Oh, I like pears. Interesting. The biases are predictable precisely because they're structured by our institutions in our society. And so drawing attention up to the institution for me gives us a point to target so that we can affect all of the individuals within that institution.
Thank you for noting that, Dr. Ford. I'm appreciative of that because, until those types of shifts and changes are made, we're putting a lot of onus on individuals to drive systemic change. So I appreciate that. Mm-hmm.
Thank you. And I'd just like to add, I love everything that's been said. Something that I'd encourage everyone to think about is, as I think we all understand the need to undo the systemic and institutional racism, think about it as a point of innovation. If it seems uncomfortable because maybe you're not used to tackling racism or you don't know what that looks like, think about it as a source of innovation. Certainly as we think about public health and the healthcare system, we love to think about technology as a form of innovation and thinking outside of the box and doing things differently. And for me, it feels very much the same. Certainly can be a source of activism, but really is just another source of innovation in a way that I think it really calls a human right, the human right for everybody to be their healthiest selves. That I know as practitioners and leaders, we all want to fight for. So I want to call everybody into thinking of it as innovation and thinking about ways to do things differently in systems and structures that have really been handed down to us to be set up in a way that has been counterproductive for people being their healthiest selves and upholding racism inside of those structures in ways that we might not even know. We may have to stop and pause and consider, how are things set up in a racist structure in a way that some people are being oppressed continuously by our practices, which we may not own, but continue to perpetuate by being complicit by not changing and innovating to make things more equitable for all.
I really love that, in part because I think it's helpful. I know from many people that I've talked with that they feel intimidated to do anything. And so I sometimes draw a distinction between what does it mean for me to do my own personal anti-racism work, and what does it mean, for instance, when CDC Director Walensky said racism is a public health problem. To my mind, that means there are tools in the public health toolbox that can be applied, and in fact, that must be applied to this problem. And so I believe that even if we actually do not support the notion of racism being a public health problem, that by it being named one as part of our field, that there are in fact strategies that we can take so that we are actually doing our job with fidelity, regardless, So I don't think people need to be afraid of what this means about their own personal sense of identity, because part of it on some level is just, this is just part of the work of being a public health professional. And I can use these tools, once I learn them, to actually do that work.
Thank you, everyone. What a wonderful discussion. I was wondering if we could, if you could provide one or more examples of innovations that have helped to solve some of the challenges that we just discussed.
This is Tracy. I'll share one with regard specifically to data evaluation and research. And I offer this as part of the challenge that I love that Dr. Ford presented to everyone. Because I think it exemplifies that this doesn't have to be something complicated, and it's not outside of anyone's reach. And inside of that, it's just the opportunity to ask the question to those who are most impacted by any issue or topic or health outcome that you seek to address. Just ask, as opposed to doing it in a bubble with just your institution, your municipality. Ask the community, ask the population that you're serving. Ask them what are the barriers and facilitators to them being more healthy or addressing that particular health outcome. So often we take that for granted about the power of asking and being in communication and being in relationship. And I think that goes back to what I was sharing in the beginning around inclusion and the power map. So sometimes we're just so used to doing things with our coworkers and maybe our partners, but going to the source of the people most impacted can make all the difference. And from a research and data perspective, even if people haven't been exposed to it that way, I think of it as the most rigorous evaluation, the most rigorous research, because it's not us doing that as quote unquote the experts, but instead allowing the people most impacted and directly holding the outcomes that you seek to identify and you seek to impact as the experts about what they need and how to best support them.
Thank you, Dr. Hilliard. Yes, please.
I'll use an example, and I know Dr. Ford and I were both thinking about Greensboro. I don't know if you're going to share that example or not. I'll share a different one just in case.
Hey, go ahead, because you're right there.
No, it's okay. I'll share something that is a personal experience actually in Baltimore. Part of my background is around child health and early childhood development. I've spent quite a bit of time focused on that, and it's such an important part of the life cycle. Like, I won't go there though. I won't get on that soapbox. But I did a lot of work in looking at bringing together partners to improve well-being for children ages 0 to 5. And part of that, my introduction to doing community work together with other partners, using this data-driven framework that I'm sharing, was with a program called a Leadership in Action program. And someone asked a little earlier, what does that mean, disaggregate the data? So I want to loop back to that question I saw in the question and answer. So when we looked at the data for 5-year-olds, this was back in 2003. When we looked at the data for 5-year-olds who were entering kindergarten ready to succeed, we saw that only 27% of kindergartners were entering kindergarten ready to be successful. And this was a developmentally appropriate assessment of 5-year-olds by their kindergarten teachers. And so and this was in the state of Maryland again, and we not only had data for Baltimore, where I lived and worked, we also had data for other counties across the state. The beauty of this data was that it was broken out by race, ethnicity, gender. Where was the prior setting? Were they in a childcare center? Were they at home? Were they in a nursery? Were they in family provider? So that's what disaggregated means for the person that asked that question. It means you look at the data and you break it down into smaller and smaller parts by the groups that are in that data. It could be gender, race, ethnicity, or other things, zip code even. But the story I want to tell here is that we looked at the data by different populations and created strategies that were appropriate for those populations, right? And understanding that different, based upon where people lived or what their cultural background was, they needed services that were appropriate for them. And by coming together with 40 partners across the city, we created a 5-year action plan for achieving school readiness that included culturally responsive strategies based upon these unique populations. And it went from 27% of children entering kindergarten ready to succeed. I think in 2 years, it went up to 54%. And then those changes were sustained over time. And so I think that is an example of what does it mean to have a culturally responsive approach that advances equity.
And there are teams who have been working to literally identify racism, measure it, and correct it within healthcare itself and in public health settings. And the example that we were just talking about is an example called the ACCURE project. That's an acronym, ACCURE. ACCURE, a phenomenal project that is a collaboration across diverse community stakeholders, academic partners, and a healthcare institution where literally community members and patient advocates sat down with management from the healthcare institution and walked through exactly, first of all, went through an undoing racism training, and then walked through the entire aspects of the healthcare system process to identify ways that racism was impacting the health of its patient population. And the healthcare organization realized it was in their interest to partner genuinely in this process. The result? An actual reduction, I believe with some outcomes, an outright elimination of racial inequities in some of the cancer outcomes.
Thank you, everyone. So as you know, ASTHO is an organization that supports state and territorial health officials. And I wanted to ask a question about advice you might offer directly to officials working in that capacity. Do you have any near-term advice that officials in those roles could take from this meeting and begin implementing in their own practice to help reduce health disparity and address systemic racism?
I'd like to start by saying the first step is to gather the data and to make sure that there's funding allocated to sustaining the collection of data and ensuring that the measures that are selected are important to the communities that you are serving, right? So you want to select community indicators of well-being that are important to that group. I'll give you an example. I've done a lot of work in the Bay Area in San Francisco. And so one of the measures that we used in that area, over time was the rate of HIV/AIDS. And so there's quite a bit of, there's quite a bit of focus on how can we reduce the rate. There was quite a bit of focus over the years and continues to be, how can we reduce those rates, especially for marginalized populations, right? And so that was a critical measure for that community. Every community should be able to select the indicators that are important to them, and they should not be imposed upon them about this is what is important. So once the data is collected, making sure that it is separated by separated by groups, disaggregated, and that also there's, I'll reiterate, a commitment not just to collecting it once, but collecting it on an ongoing basis. Because this session is about health equity and addressing racism as the root cause of that, I would say in specific that we need to make sure that we're looking at, well, there's no indicator where people of color are doing better than people who are race identified as white, but so it will not be hard to find that kind of indicator, but just make sure that the indicator is one that people who are impacted negatively by race and racism are showing up in that data in a way that you can track it as well and track improvements.
I would add one thing in terms of the data I think is really important is that the ways that racism operates, the term racism is really a huge umbrella term. And there are so many more specific, nuanced dimensions of racism. And we wouldn't even use the term racism to capture some of them. For instance, if we think about the experiences of Native Americans, we wouldn't necessarily use the term racism, though what's at work can still be characterized as racism in some respects. So I really appreciate that, that statement. I do think that relying on the literature is very important in order to make sure that the approaches that health departments take are actually going to move the needle on these different outcomes. And the books that I mentioned earlier are easy tools that provide direct access to that evidence. And I think that would be useful. The other thing that I would mention is that it's important, while recognizing that racism is a barrier and a determinant of health inequities, to also recognize the assets, strengths, and resilience that exist in communities impacted by it. Mm-hmm. In part because these communities have developed strategies to survive, and in some cases even to thrive. So what looks like a really bad circumstance might be even more extreme had these communities not developed strategies to overcome it. So I believe it's critical to do that. Otherwise, we end up stigmatizing communities instead.
Yeah, I love what's been said. And just to follow on that, I just reiterate my comments and sentiments from earlier this morning about just being in relationship and engaging community so that they can speak for themselves and they can prioritize what they need and what they want most from you. Another reflection of that is how well do the staff in your institution reflect and connect with those communities? So think about the diversity of the staff. I understand that some of you may be in a place where you may live in a relatively homogeneous community. But if there are any folks who are unlike most, it is possible that they are heavily impacted, maybe even more so because of disparate experiences due to race. So thinking about who's staffing and doing the work in your institution and how that's reflected again in those perceptions and biases that we all have that we bring to the work that we do every day, because we are whole people. We can't really separate who we are at home and who we are at work. We are one person, one human, one system of being. And those perceptions influence, particularly as we think about our work with data and research, always influence the questions that we ask, how we think about approaching problem solving. And that's the beauty of really being in relationship and communication to be culturally responsive with the community to speak for themselves and to guide us in how we can best serve them. So just wanted to offer that up again and thinking about who you are as an organization, an institution, and how you connect with community.
I'd like to follow up on that if I may. So I mentioned the intercultural development inventory, and I'm bringing that back here because after polarization, the next orientation is actually minimization. And minimization is an orientation where people focus more on commonalities across culture. They de-emphasize the differences. And what Dr. Hilliard was just saying is just so vital to recognize, even when you're in what seems to be a homogeneous community, you have some diversity in that community. And I recently was speaking with someone using, the language of minimization and saying, and she mentioned that, oh, I live in a rural community. Everyone is pretty much the same. We all get along. Everyone's the same. And she happened to be race identified as white. And so I asked her, tell me a little bit about your community. And so she said, tell me about your neighborhood. And she said, well, we're all farming people. We're agricultural folks. And she said, and then I said, okay, what about and then she said, well, across the street, I have a family that is from Korean background. And then she said, well, oh, my neighbor over here is from, and she said, a different culture. And I said, well, what are you noticing about what you're sharing right now? And so she said, oh, well, I guess maybe there are some differences, amongst us. And so people who are in that orientation of minimization tend to see everyone being the same, and we focus on those universal principles across cultures. And that's how many of us were brought up to be, focusing on, I treat everybody the same, we're all the same. But we know with intercultural competence that everyone is not the same. There are differences across cultures. And when you begin to move away from that focus on commonalities and thinking, oh, maybe there are some differences that people are experiencing who don't look like me, even though we're all from a similar community. That's when you can begin thinking about, as Dr. Hilliard was saying, how can I then address the needs of these individuals who are unique to this whole group of people?
Thank you,
Wonderful.
everyone.
This is Tracy. If I could just add one more thing. I know we probably feed off of each other as panelists to some degree here. I love everything that's been said. And what that reminded me of is, yes, I think all of us being who we are, we do love to rely on the data, rely on the literature. But what I call us back to, I think it's a both and. The value and beauty of also being responsive and prioritizing the voices of the community you aim to serve is think of them as the experts. Think of them as the ones with the key to the knowledge and the way of knowing about how to exist and how to be. We can turn to the literature that I'm sure many of us all love and is our first love as researchers and evaluators and even practitioners. But remember, at times, that has all been produced from a bias and inside of a system that historically has not prioritized those voices. So feel free to always question. If it doesn't match your instinct or if it doesn't match certainly what the community says, I would say trust and verify. Trust and verify with the community what they think of what the literature says, what they think of what the data says, because we know, particularly when we talk about quantifying things, for all those reasons of data being presented in aggregate and limitations of data collection, it can be skewed and it cannot represent at times the people that we're aiming to serve. And so really by lifting up those qualitative stories, especially directly from those that you hope to serve, it's a marriage, I think, of the quantitative information that's rooted in the literature or current data that's produced by your institution, and then the stories of those most impacted that you hope to serve.
Thank you, everyone. I really appreciate all of your comments. And following up on that, we have a question from the audience about the policies that need to be implemented to improve the quality, and by that they mean the accuracy and availability of race and ethnicity data in public health research and practice. So what policy-driven changes need to be made to assure better access to that data and that data is collected in a rigorous and meaningful way?
I'll start. We could have an entire conference just on this one question. So thank you for the question. I think it's important to know why we are collecting the race and ethnicity data each time we collect it. And that will allow us to collect the correct, ask the right question so that we get at what it is that we want to get at. We do have existing policies guiding the collection of race and ethnicity data, but part of what happens, a big part of what happens is in the area of practice. So what happens when it comes to actually collecting it? So I think that there needs to be more training in terms of dealing with the existing guidelines. That's one. And I also think we need to rethink what we're doing when we collect race and ethnicity data. I would love to see us collect these data in ways that treat these variables as indicators of people's risk for certain social exposures to racism, rather than as inherent characteristics or traits or attributes of the individuals.
I want to say something that may not, I hope this answers your question, but what comes to mind for me is that in many federal funding opportunities, statewide funding opportunities, we use models like the socio-ecological model, which defines community in a way that is organization to organization. And we recently have discovered this with some of the work that I'm doing with the Maternal Health Learning Innovation Center at University of North Carolina at Chapel Hill. And what we're just edging into this conversation about the definition of community and what that means. And so there's so many funding approaches that are funding opportunities that are asking for people to use specific models or specific frameworks that are really contrary to being able to address race and racism. So I would say, and Dr. Hilliard was saying about innovation would be how can we look at these models and authentically say, this is not working anymore. In 2021, we have to face reality and look at models like the socio-ecological model. I'm going out there and being brave. I said that we have a brave space. So like the socio-ecological model, and that defines community opposite to the way that we're talking about right now. Maybe not opposite, but very differently than the way that we're talking about right now. So I think policy, when we think about policy, we need to relook at requirements of specific policies and make sure that we are not using outdated models that are driving the policies on the ground.
Thank you, Ms. Epps. Dr. Hilliard, if you would like to respond, we have 3 minutes left in the session.
Sure, I'll keep it short and just say something that I'm mindful of is the impact of community organizing on policy change. And so that just brings me back to kind of summarizing the call that I've been making to engage community. And so maybe one example is thinking about how, as you may be taking on policy change around the use of data and research, engaging community organizers in your area and asking them what they think about it and what are the areas that are most important. And in partnership, they probably can get things moving in a way that perhaps you alone may not be able to do. So just knowing that historically, that's how we know significant lasting change happens, being in relationship and in partnership with the communities you serve and those that can advocate for their needs best.
Thank you. Would anyone like to offer final comments or summarize any sort of actionable steps you'd like to share with the audience before we adjourn?
I would just say that this is something that we can do, and we're not doing it alone. So reach out to those who have been doing it for some time. I'm sure we're all here to support you all.
Yes. And I'll say a first step is to talk to your colleagues about having a common language. What do we mean by when we say race, racism, equity, culture? Because there's so many definitions out there. Just sit down and talk about it and make sure you're using the terms in the same way.
Yes, agreed. And something that I would say, and I'm guessing I won't speak for them, that my colleagues here on the panel will own, is even though I know we've been brought together as panelists and subject matter experts, we are all on our journey, and everybody can be on the journey towards advancing health equity and addressing racism in public health. But no one ever arrives. We have so much work to do, and we will only get there together if we all play our part. And so any start is great, because we are all on a journey and we have to move forward together. Thank you.
Beautiful.
Ms. Epps, Dr. Hilliard, Dr. Ford, thank you all so much for joining the panel today, for sharing your knowledge and wisdom with myself and the audience, and for letting us participate in your discussion. I'm leaving feeling inspired and looking forward to what I can do to take those next steps. The panel ends here, but for those of you listening, if you're interested in watching the panel again, it will be available to watch from ASTHO's website. Later on, you'll get details about that. And we just want to thank everybody for joining the summit today and participating with us, and wish you all well as you head into the next session. There'll now be a break, and the next session will begin at 2:15. So I wish everybody a wonderful day, and hope that you enjoy the rest of the summit. And thank you again for your participation.
Take care.
That was awesome. Thank you.
Thank you.
Thank you, everyone.
Good to see you all. Take care.
Bye-bye.